Welcome everybody to our webinar on Parkinson's disease. I appreciate you being here with us. And I would like to, first of all, explain who we are, the Amac Foundation. We work in conjunction with VITAS to present these public information seminars, and it's something that we really value the relationship that we have with VITAS Healthcare to do this. AMAC, the acronym AMAC, AMAC stands for Association of Mature American Citizens. AMAC itself is I guess a senior support organization is what I would call it. We are very active in Washington, and we basically represent the interests of senior citizens in Washington to make sure that their interests are getting to the appropriate people in Congress and getting the appropriate attention. I won't say much more about AMAC itself. The AMAC website, amac.us, is one that I would encourage you to take a look at. It covers all of what AMAC does. And it's a membership organization. We have benefits that are available to members. But I want to focus more on the AMAC Foundation. The AMAC Foundation is affiliated with, separate from AMAC Inc. AMAC Inc. is a private membership company. The AMAC Foundation is a public benefit corporation, a 501c3. And we operate nationally. We're based here in Central Florida, and a lot of the seminars that we do, face-to-face seminars, are done right here in North Central Florida. But we typically do topics like this one we're doing this morning, and we record them and load those videos on our website so that people across the country can watch them at their convenience. AMAC Foundation, as I said, is a 501c3. We provide services to the community. Our mission is support and educate America's seniors. We conduct seminars like this frequently. Now that we're getting back into the post-pandemic stage a little bit, we're able to do more. Prior to the pandemic, we were doing 2 or 3 of these a month, and we had to stop. And so now we're getting back into the business, and so we're back up to doing at least one seminar or 2 seminars a month on average on various topics that are important to seniors. So seminars is one thing that we do, public seminars. We also operate a service called Social Security Advisory Service, and that's really our primary mission at the foundation. Is we have 7 trained and accredited advisors that handle Social Security questions. People that are aging into Social Security and have no place to go to get credible information. We handle on average 500 to 600 inquiries every month, and an inquiry can take 5 minutes or it can take 5 hours. It just depends on how complex. And if you've ever looked at Social Security, you know it's fairly complex. Mm-hmm. And so our mission is to help people. Basically, there is no place for people to go to get real credible information that fits their circumstances. Everything that we address in Social Security is situational, and there are no simple answers typically to Social Security. You have to understand the person's situation in order to give them the correct advice. That's pretty much what we do as a foundation. And again, we are a public benefit corporation. We do not charge for anything that we do. We provide the counseling service completely free. And so far, since we started this service in 2016, we've provided over 17,000 counseling sessions. So it's a very popular service and very much needed service as well. And we're really proud of it. But the seminar part of what we do is something that I consider equally important to keep the public aware of important topics. Parkinson's disease is an important topic. I know there are statistically something like 1 million people living with Parkinson's in the United States. And I think every year, I read a statistic, every year there are about 60,000 people diagnosed with some form of Parkinson's. So it's a major health issue, and we try to focus on those kind of issues, and that's why we wanted this one, have someone that has expertise such as yourself, come in and talk about it for our listeners. So with that, I'll turn it over to Dr. Rodriguez.
All righty. So, and that sounds like a great organization. I have to say that I was not aware, and I think that this is very valuable information that I will surely share with the patients coming to my clinic, which are
Please do.
right in the
Please do.
age range where the foundation might be able to help them. So, and before I get going, how long do I have to speak?
Well, we have it set for an hour and a half. So, you know, something within that time frame is fine.
Okay, perfect.
Yeah.
Perfect. Well, I don't think I need to take that long, but let's go ahead and let's get going. Is this a good time to begin?
For sure. I just want to say thank you, Dr. Rodriguez, and I want to make a little bit of brag of why you are and why you we invite you, because you're one of the really high recommended specialists, neurologists. And if you can talk a little bit about you and about your practice before you start, so our audience can see and can know a little bit about your background, will be amazing.
Oh, perfect. I'll be happy to. So, you know, once again, my name is Dr. Ramon Rodriguez, and I am a board certified neurologist. I did my training at the University of Texas in Galveston. I went to medical school at the University of Puerto Rico in San Juan, Puerto Rico. And after I finished my training as a neurologist, I had the option of going to work, or I had the option of even studying a little bit more. So I decided to study a little bit more, and I did something called a fellowship. And my fellowship is in surgery and management, medical and surgical management of movement disorders. And obviously the main movement disorders that we see in our practices is typically Parkinson's disease and everything that looks like Parkinson's disease, but we also manage people with tics and walking problems and other tremors and conditions called dystonia and so on. And you know, all my career, I have been an academic physician. I was a professor, one of the faculty members at the University of Florida in Gainesville, where I had a wonderful time there for 11 years. And then after that, I joined the University of Central Florida, and I have the honor of working at the VA Medical Center serving veterans. And I did that for 4 years. However, you know, I was still a little bit restless, meaning that I have been working in terms of doing some research in two main stages of Parkinson's disease. So early Parkinson's, so looking for something that might help slow down, stop, or cure Parkinson's disease. So that will be number one. And then second one is the management of the very advanced patient, right? So people that they're finding that the medications are not working very well, or there are many complications of their condition. So we have been able to find better treatments so that we can improve the lives of that patient population. So you know, I had an opportunity to open a practice where we were able to combine both the research aspect as well as the clinical aspects, you know, the opportunity to take care of people. I have been doing research for over 20 years now, and I have been, you know, blessed with the opportunity to teach many doctors and many other people all over the world. So that has been a wonderful honor. And but still, you know, the most wonderful thing I do every morning is having the opportunity to wake up, have people come to my clinic, being able to sit down with them, talk about their problems, try to see how we can make this better. I have a wonderful team. So you know, my wife is my boss, and she's the clinic manager. She makes sure that everybody gets the care that they are expecting. And then I have a wonderful team of people surrounding me, both in the clinical and the research areas, that just allow me to do everything that I do in the clinic. And I have other doctors that have been joining my practice that they share the same way of thinking. So we have been very fortunate about that. So with that, let's go ahead and proceed to talk a little bit about Parkinson's disease. That's the theme for today. And I will be speaking about what we call the atypical Parkinsonian syndromes, right? So, you know, many people go to the doctor and, you know, they have Parkinson's disease, they get their medicines and everything flows certain way. However, Other people go to the doctor and the doctor tells them, you know what, you have an atypical Parkinson's. And that is an extremely common question, right? So let's go a little bit on the background of Parkinson's disease. And as Gerald said, you know, there's about 1 million people in the United States dealing with Parkinson's disease on a daily basis. And we're expecting those numbers to increase. And they increase, number one, because we're identifying this problem more and more, right? You know, in the past, they used to say that, you know, that's just old age, right? Now we recognize it's not just old age, right? You know, there seems to be a condition going on, and we try to provide the best care for those patients. And then at the same time, you know, I personally believe that there are certain things in the environment, right, that I believe might be associated with this increased number of people developing Parkinson's disease. And, you know, environmental things, you know, I have, this is my personal opinion, right, where I feel like there are some issues with fertilizers and chemicals and stuff that we get exposed through our life that might be the trigger for this kind of conditions. Now, when we talk about Parkinson's disease, you know, for most people, these are conditions where people begin to have symptoms between 55 and 60 years old, and the diagnosis is typically made between 60 and 65. So 55 to 60 is the typical onset of the symptoms. 60 to 65 is where most people eventually gets diagnosed with the condition. Now, how early Parkinson's disease can happen, right? Because we have a condition called young onset Parkinson's disease. And I have to tell you, the youngest patient that I diagnosed was 25 years old. So this is something that might be observed very early. And after 65 years old, that incidence of Parkinson's disease continues increasing over time. So there is even higher chances of a person developing Parkinson's disease. Now, we always associate Parkinson's disease with tremors, right? And actually, let me explain to you what are the main symptoms of Parkinson's disease, because you suddenly might start thinking about some family members or some friends that might be struggling with a medical issue that have not been identified fully yet, and it might be Parkinson's disease, right? So the most common symptom, the one symptom that every person with Parkinson's disease has, is slowness, right? Everything becomes slower. It takes longer for them to take a shower. It takes longer for them to get ready Sunday mornings to go to church. Suddenly, you know, dad that used to be the first one finishing his meal at the restaurant, now he's the last one, right? So those things begin to change. And then people develop some stiffness. And while you cannot see stiffness, it is typically observed as changes in the dexterity, right? So people have issues with dexterity. I cannot do things the same way that I used to. And then about 65 to 70% of people with Parkinson's will have the typical tremors, right? And the tremors in Parkinson's have a particular quality. They happen while the person is at rest. And by that, what I mean is the person is sitting down watching TV, and suddenly the hands begin to shake. And that is the opposite from what we see in people with what we call essential tremors, where in essential tremors, the tremors tend to happen when the person is using their hands, when they are doing something, when they are using the screwdriver, when they are using a pen to write something, when they're signing their names, or when they're using a screwdriver, right? So people with Parkinson's disease typically is able to manage that easier compared to somebody with essential tremors. So 74% of the people with Parkinson's will have some tremors. The other 30% will have what we call the stiff and slow variant of Parkinson's disease, right? And those patients are slower, they're stiffer, they have more balance issues as well. And you know, comparing this with other people with Parkinson's, they seem to be a little bit more challenging, right? But nonetheless, we still treat them. We take the challenge of caring for those people, and many of them are able to live a long-lasting life. You know, so long that I always tell people that most likely they are going to die from something else that is not Parkinson's disease, right? Maybe a stroke or a car accident or pneumonia. We'll get to them before the Parkinson's dose. So people with Parkinson's, they are well known to live 10, 12, 15, 20 years, right? And remember that for a condition that begins at 65, 70 years old, for many of them, having another 15, 20 years is basically what the typical age range for the population is in the United States. Now, one of the characteristics of Parkinson's disease is that they respond strongly to carbidopa, levodopa, which is the main medication that we use for the treatment of Parkinson's disease, right? And levodopa it's an amino acid actually, and this compound was discovered in 1918. And by 1920s, they were already making this in the lab. However, there was no use for it initially. It was in the late 1950s, 1960s that the research and the idea of using this in Parkinson's disease started. And there was quite a large amount of research, and the benefit at that point that people with Parkinson's were obtaining for those that were able to tolerate the medication was quite robust. So at that point, many doctors thought that, that might have been the cure for Parkinson's, right? However, unfortunately, over time, we began to understand that the disease, the medication was good to make the symptoms of the condition better, but the symptoms were still progressing, and there were some challenges associated with the disease. And because of that, then some other therapies started coming out, and research had to continue in order to make things better. So what I'm going to do is now I'm going to make a quick pause to talk about the atypical Parkinson's syndromes, right? Because the people with Parkinson's typically have a very robust benefit, and they feel like they're turning on, like somebody's is recharging my batteries after they take their medicines. But there's still a group of people that they have been diagnosed with Parkinson's, and they look a lot like Parkinson's, but unfortunately, they do not get that robust benefit from the medication, right? And it is at that time that we begin to think, am I dealing with an atypical Parkinson's? And by atypical Parkinson's, what I mean is these are conditions that look very much like Parkinson's. So they are slow, they are stiff, they might even have some tremors, but interestingly, a lot of them do not have a lot of tremors, and they have a lot of balance issues, which is the other symptom that we see in people with Parkinson's disease, right? And when doctors treat them with medicines, they do not seem to get that robust benefit from the medication. So the first one I'm going to talk about is something that we call Lewy body disease. And Lewy body disease is probably the one that looks the most like Parkinson's disease. These patients are becoming slower. They are developing some stiffness, right? They have some balance issues, and some of them will have some tremors. However, the one characteristic of this patient population is that early in the disease, within the first year, they tend to have some hallucinations, right? And these hallucinations are typically that they see people that are not really there. They see children, they see pets and animals. And sometimes, the hallucination is very mild in the sense that they have what we call a delusion of presence, where they feel like there's somebody in the room, and then they just look over their shoulder, but nobody's really there. And unfortunately, these conditions will continue progressing over time. And they are also associated with very vivid dreams. So these people go to bed, and while they are sleeping, they tend to have sort of very vivid, sometimes violent or aggressive dreams, And when I say violent or aggressive or argumentative dreams, it's because, the dreams are sometimes like, they are at the hardware store, and there's an argument over the price of the product that they're purchasing, right? It's like you can hear them talking like, $2 is too much for the nut or the bolt, right? That should be cheaper. That should be 25 cents. So you can hear them actually talking about these things. And many times the significant other is nudging on them like, hey, you know, what is going on? What are you talking about? And then sometimes what happens is they begin to act this out, right? So they start moving their arms, and sometimes they might hit the person sleeping with them. So it's not uncommon eventually that the significant other might end up moving to another bed. And what happened is that for the first 5 years of the onset of this condition, most of the people are actually diagnosed with Parkinson's disease. But then after 5 years, they realize that they're progressing a little bit faster compared to Parkinson's, and they're having a lot more memory issues. They're developing more cognitive issues. So that is what differentiates this Lewy body disease from the typical Parkinson's disease patient. You know, as I mentioned to you, Parkinson's disease is a slowly progressive disease, right? It's not, in these days, Parkinson's is not a death sentence like people, you know, many times think, because they are able to live as long as they were going to live anyway. So Lewy body disease looks a lot like Parkinson's, but they have hallucinations and they have memory problems very early in their condition. The next condition that is an atypical Parkinson's is something that we call multiple systems atrophy, okay? And multiple systems atrophy, or MSA, that is the short for this condition, is a condition that once again presents with slowness, presents with stiffness. There might be occasional tremors. However, there will be other symptoms that will differentiate this from early Parkinson's disease. So for example, one of the symptoms that we most commonly observe in this population is the term orthostatic hypotension. And what that means is that people with this condition, they feel dizzy when they stand up, to the point that some of them might even pass out. Some of them will black out. And what happens is that when they're standing up, they might experience a drop in the blood pressure. And it is a drop in the blood pressure so significant that if you are not keeping the blood flowing properly into the brain, you are going to feel dizzy, and some people eventually are going to pass out. Along with the orthostatic hypotension, this population suffers very frequently of severe constipation. So changes in the blood pressure when standing up, constipation, those are two very common symptoms in these people that have MSA. And at the same time, they do not have the robust benefit to the carbidopa levodopa medication that is typically used in people with Parkinson's disease. So in the first 2 to 3 years, this population might experience a 10 to 20% improvement with the medication compared to people with Parkinson's disease that tends to have a robust benefit from the medication. They feel like, wow, this medication is very useful for me. So that is why we still use medications like levodopa on this population, because 10 to 20% improvement is better than no improvement at all, right? So that is why your doctor, if you're able to tolerate the medicine, might choose to continue with this medication. So this MSA, you know, come in 3 different varieties. One of them is the one that I just explained to you, where they have these changes in the blood pressure and severe constipation. The second type is associated with severe unsteadiness when walking. And the right term is ataxia, or cerebellar symptoms, which basically means incoordination. So these people are not weak, but they just cannot coordinate the movements, right? So, you know, I always say, this is like playing the piano for the first time, right? So, you know, you might sit in front of the piano and you will press the keys and you will hear the sound, but it just doesn't sound pretty, right? It doesn't sound like what you expect. So the same thing happens in the brain, where there is no weakness, you know, there is power in the extremities, but people cannot just coordinate them properly in harmony for the particular movement to happen properly. So that's what the terminology ataxia really means, which is observed in that second type of people with MSA. And then the third type is people that just become slow and stiff. period. They're just very slow and very stiff, and they look very much like Parkinson's, but they just do not get any benefit from the medicine. So obviously, this, just like Lewy body disease, unfortunately, these conditions do not have a robust benefit from the Parkinson's disease medicine. They get a little bit, but not a lot. So we still try the medicines because a little bit is better than nothing, but they don't have that robust benefit. Now, the other condition, and these conditions are actually fairly similar, is a condition called progressive supranuclear palsy, or PSP, progressive supranuclear palsy. And this is a group of patients that they develop some slowness, they develop some stiffness, but right from the onset of their condition, they begin to fall. They're falling, and they typically fall when they're walking backwards. And let me tell you what happens. You know, in the United States, we know that almost every door opens backwards, right? So, you know, I go to my refrigerator and I open the door backwards, and I might need to take a step back to allow it to open. When I go to many places, you know, I just pull the door, right? And when you pull that door, you need to take a step backward. And this is when this patient population, these people are going to fall down. So, you know, their children bring their parents because, you know, mom or dad, they're falling now, you know, they're walking, everything is going well. But as soon as they stop to open the door or try to get the door to get in the car or something, they're falling. And then typically, because they also have a little bit of difficulty coordinating their eyes, they fall when they are going through the curbside. So many times that will be the other situation. And it's because, remember that your eyes have to be focusing very well for you to judge distance. But these people, for some reason, are not able to have that proper functioning of their eyes. So they cannot measure very well. And when they're going through the curb, they trip and they fall down. So that is the classic history. And even so, as they come and they give me a history just like this one, I'm able to tell what is happening to this population, right? And this one is quite challenging because these patients early in their condition develop difficulty swallowing. And while all these conditions can have trouble with swallowing, these ones in particular might have something that we call aspiration. And aspiration means that some of the food might be going in the wrong pipe. So it might go into the lungs. And if a bacteria is caught up there, then people can develop what we call aspiration pneumonia. And those conditions, you know, they can be fatal in people that are 60 years and older, right? So that's why we have to be very mindful. And when they get diagnosed with these conditions, we're always monitoring, making sure that they are able to eat and drink well and to avoid the possibility of having this aspiration. And then the other condition that I'm going to speak about, the other atypical Parkinson's, is called Corticobasal Degeneration, okay? Corticobasal Degeneration. And this type of Parkinson's, which is an atypical Parkinson's, just the same way, just like the others, in the first 2, 3, 4 years, they might show some benefit to the Parkinson's medicine, but after that, when the condition moves further, they stop responding well to the medicine, right? And at that time is when people end up coming to the movement disorder specialist, because they say, you know what, initially he was getting some benefit from the medication, but now we don't see that benefit that he was having before, and he's having more issues with dexterity, and he is having more issues with mobility. So, you know, what is happening? You know, what is wrong here, right? And this particular population have certain symptoms. So number one, always one side of the body is more affected than the other side, right? So people with corticobasal degeneration, one side of the body is typically much worse than the other side of the body. So one side seems to be working well, the other side does not seem to be follow what the brain is asking the extremity to do, okay? And these people can develop a condition called dystonia. Dystonia is an involuntary contraction of the muscles. And people with this condition, sometimes they can develop an abnormal posture of the hands. Let me, like the fingers just go into certain posture, for example, and they just cannot use the hand properly. And that causes a lot of pain. It can cause a lot of discomfort. And if it is the dominant hand, right? If they're right-handed and the right hand is the one that is going through those symptoms, then it becomes very challenging because they might not be able to feed themselves properly. Just imagine going to the bathroom, do the kind of things that you need to do, right? So it can become quite a challenge. And then the other problem that happens in this population is that as the disease moves along, they might develop something called apraxia, A-P-R-A-X-I-A, apraxia of the gait. So they have major issues with their walking, where the extremities, again, are very strong, but they just cannot get their brains to coordinate this function of one foot going right in front of the other in order to walk properly. So these people will stand up and they just stay there. And you ask them, hey, walk, move forward. They just cannot get that activity going on. So obviously they end up confined to use a wheelchair or a scooter in order to be able to displace themselves from one place to the other. So these are what we call the atypical Parkinson's syndromes, and they look very much like Parkinson, but they are not true Parkinson's. There is still one more that I forgot to mention, and it's the one that we call vascular Parkinsonism, okay? Vascular Parkinson's. And vascular Parkinson's is a condition where it is typically seen in people with previous history of high blood pressure or diabetes and people that are smokers, right? And what happens is this. When a person has vascular Parkinsonism, the cause of this condition is that they had very, very tiny strokes, very small strokes in the brain. Small enough that they are not going to develop the typical weakness or difficulty speaking that people typically see somebody having a stroke. They just wake up, they might not feel good that morning, right? And they just don't pay a lot of attention, but then by the afternoon, they're feeling better. So it may have been that they had a very small stroke that is causing, it's causing just minimal symptoms, but nothing that is out of control, right? So that's what vascular Parkinsonism is. And this is why, this is the main reason why when somebody is being evaluated for Parkinson's disease, we get an MRI of the brain or a CAT scan. Number one, to make sure that there's not a brain tumor or something, that is causing this problem. Number two, to look for vascular Parkinsonism as well, right? So these are the main conditions that looks like Parkinson's disease, but they are not true Parkinson's disease, right? So this is what we call the atypical Parkinsonisms or atypical Parkinson's or secondary Parkinsonism. Some people call it Parkinson's plus syndrome. They all refer to the same group of conditions that I just talked about. Now, once a person is diagnosed with Parkinson's, so now we're going back to Parkinson's disease. So we spoke about Parkinson's, and then we spoke about things that looks like Parkinson's, but they're not really Parkinson's. But going back to the Parkinson's, there are multiple treatments, and there's a lot of research going on to try to make the lives of people with Parkinson's disease better. So the main medication that we use in Parkinson's is called carbidopa-levodopa. Levodopa is the active ingredient. And levodopa is a naturally occurring amino acid, right? People think, I don't want to take a chemical or anything like that, but levodopa is a naturally occurring amino acid. There are certain foods that are rich in levodopa, like fava beans. So the Portuguese, Brazilians like to eat fava beans. There are some plants in Hawaii that sometimes people eat them, and they eat a lot of them to the point that they develop the side effects typical of the medication for Parkinson's, right? And then there is a bean from India called mucuna that is rich in levodopa. So some people prefer to take the natural product, which is basically an extract of those plants, or you can take the medication that your doctor will give you. I have to say that typically the medication given by your doctor is going to be much less expensive than trying to take a natural product, right? You know, we're talking $300 to $500 for the natural supplement versus $25 or less for the medication that you will get in the pharmacy. And this medicine is the main treatment for Parkinson's. It changed the course of Parkinson's disease. People live longer, they have better quality of life, they are able to control the body much better. But unfortunately, as Parkinson's disease advances, there are certain complications. So we have created other medicines that are kind of the supporting actors to help levodopa work even better. And when the condition progresses to a certain point that the medication does not seem to be providing the best benefit, then we have multiple things that we can do. So one of them is a treatment that we have been doing for the past 20 plus years, which is called deep brain stimulation. It's a brain surgery that we use in people with Parkinson's disease. It is very useful for the tremors. It is very useful for stiffness. It is very useful for the slowness associated with Parkinson's. It is not that great for balance issues. And I make this comment because many people tell me, doctor, I can live with the slowness, the stiffness, and the tremors. It is the balance affecting my walking, the main problem that I'm having. But unfortunately, having this surgery is not a guarantee that the balance is going to get better. And, you know, after doing over 2,000 cases of this over the last 20 years, I have to say that I will not expect to see much improvement in terms of the balance. Okay, some people do get it, and we get very happy for them, but for most people, they're not going to get that benefit. There might be some people that they say, doctor, I do not want any brain surgery. I don't want anybody touching my brain. So there is another option, which is a therapy called DUOPA, D-U-O-P-A. And this one still requires a small surgery. So the person will have a small tube. It's a medication infusion port that is inserted in their stomach. And then they get the medication via a small pump that they carry with them. And this pump is giving them X amount of medication. Your doctor is going to adjust the pump for the right dosage for you. And people are getting the medication just about every minute, right? So the pump runs automatically. The pump is trying to imitate what the brain should be doing, but it's not doing because of the Parkinson's disease. And these medications are proved to be very useful in people with Parkinson's disease. Other than that, you know, we're even working on less invasive therapies, you know, subcutaneous therapies to make the life and the symptoms of people with Parkinson's improve and much better. So we're looking forward. I'm hoping that within the next 3 to 4 years, we're going to see some of these new treatments available in the market for this patient population. Now, you know, I'm not going that deep into the treatment for Parkinson's because, you know, it is not easy. There are certain complications, and that might take another hour, you know, for me to explain properly. However, I want to talk about what else we can do that is not taking a medicine for Parkinson's disease, right? And just like with many other conditions, right? You know, if you have a heart condition, you had a heart attack, right? You went to the doctor tells you, doctor, you know, Mr. Smith or Jerry, you know, you have 3 arteries clogging your heart, right? And here is the medicine. But if you continue being a smoker, you continue eating, you know, a diet that is not good for your heart, you know, you're not going to get too far. So by that, what I mean is there are lifestyle changes that I believe are going to be very important if you have Parkinson's disease or any other neurological condition that are going to be critical in order to try to slow down or allow you to help manage your condition better. So I always tell people that the #1 treatment for Parkinson's is exercise, right? And they need to exercise 3 to 4 times a week. And I tell my patients that they need to put exercise just like any other business appointment that they might have. They have to put this in the calendar and they have to respect it, right? And half an hour of exercise, doing a little bit of cardio, maybe a little bit of weightlifting, and a little bit of stretching is all that you need, right? It's not, it doesn't have to be something where you are, lifting a lot of weights and you don't need an expensive membership to a fitness center in order to do this. These are things that you should be able to do at home, right? So physical exercise is number one. Number two is cognitive exercises. So you have to train your mind, right? And the last thing that I want to do is just sit in my couch at home, watching Jerry Springer all day long, reruns of Jerry Springer or something like that, right? So you can watch 1 or 2, but listen, after that, you need to do something that makes your mind better and makes your mind even stronger, okay? So reading, doing, building puzzles, there are computer games that are quite useful, even more, try to learn a new language, right? And so those things are going to get your mind busy. And I am going to tell you something. These days, if you learn to use YouTube, you will find that there will be so many things that you can learn, new languages, new games, new other things, right? So that might be a great idea that you can do to make that better, right? Then the other thing is that you have to sleep well, okay? So good sleep is very important. And obviously try to make sure that you're not sleeping all day long, because then at night you're not going to sleep, right? So try to, it is okay for you to take a nap in the middle of the day. In the US, we don't do this, but the rest of the world, most of the countries have siesta time, right? They take a break between 1 and 3 p.m. or something like that. They recharge their battery. So that is okay. You can go ahead and do that, right? And then the other thing is you need to socialize and you need to get together with really good people, okay? You need to socialize and you need to get together with really good people. So take away the drama out of your life, just get together with people that makes you feel better. And I'm going to tell you something, once you're a mom, dad, or grandpa, you become a drama magnet, right? Everybody comes to you to try to fix their problem. You love them, right? Like as I tell my kids, I love you, but you're gonna have to deal with that yourself. I can give you some advice, but I'm not going to take the lead with this, right? So we'll watch them, we'll make sure everything is going fine, but you cannot get that as your problem at the same time, okay? Number 5 is the diet, right? So I always tell people, if you can afford to eat healthy in-season foods, go ahead and do that, okay? So that will be number 1. And second, if you can afford to eat organics, right? Because I personally believe, this is my opinion, right? My opinion is that a lot of these chemicals that we consume in our daily diet might be the one thing that is triggering Parkinson's. I always say that some people carry a risk to develop Parkinson's, but something has to pull that trigger that will activate the disease. And there has to be something in the environment that might be what is triggering these conditions, okay? So that will be the next one. And then the next one, number 6, is you have to do some meditation, all right? And I always make this comparison, that when you're working on your computer and your computer is not working well or is freezing, what do? You turn it off and let it run a course. And when it comes back on again, it is working much better, right? So the same thing with your body, or, I always, that the computers, they have this Control-Alt-Delete function that just resets the whole thing. But guess what? You know, I'm looking my Control Alt Delete button in my body. I cannot find it, right? So the way that we have to do this is we need to do some meditation. We need to take 5 to 10 minutes every day, all right? And just listen to nice music, just relax yourself, right? Just let your mind wander, because that's when you're giving your mind an opportunity to reset, relax, and then chances are that things are going to get better. And I mean that many times the stress and all that begins to feel better after that. It just allows you after that to see things from a different perspective, okay? So you know, those are my recommendations for people with Parkinson's disease. It's not only medicines, right? You know, as doctors, I just don't like to be throwing medicines. You know, there is a part that I'm gonna do with the medications, but I need my patients to do their part. And that is, you know, that those lifestyle changes that are very important in terms of exercising regularly, eating the healthy diet, socializing, living well, and make sure that they're getting the adequate sleep. Okay. So with this, what I'm going to do is I'm going to make a pause here, and you know, if any of you have a questions that you would like for me to answer, I'll answer it. Otherwise, I have to tell you that you know, I think that this is sufficient information at this point for you to have a good idea about what is Parkinson's disease, what are the Parkinsonian syndromes, the atypical Parkinson's that look like Parkinson's, but it's not real Parkinson's disease. And with this, I'll tell you that there are many doctors who are working really hard to find a cure for Parkinson's and to find better treatment. So if you have Parkinson's disease, you know, pay attention to what is happening in your community, because sometimes there might be research studies going on where you might be able to participate, and you can help make this these treatments even better.
Excellent. This is exactly what we had hoped for, a good understanding, you know, of exactly what Parkinson's is. And I think we've gotten that. This has been tremendous benefit to me. Now I understand it a lot better.
Well, you know what, and this is very important, because as you know your condition better,
right,
then you can make better decisions, right? And number one, you have a better idea, understanding what your doctor is trying to tell you, and you have a better idea about what to expect from these conditions, right? And sometimes people tell me like, but doctor, you know, I don't see any benefit with the medicine or this and that. And I have to tell them, listen, you have what we call an atypical Parkinson's, and that is why, you know, and not all the time that means good news, right? But at least if you know what is going on, you know, you stop looking for that magic pill or magic cure that is going to make things better.
Yeah.
right.
Doctor, I want to ask you something. A lot of people say, you know, talk about dementia. And obviously, some people can have other disease related or at the same time. But when they are diagnosed with Parkinson's, that can be related as well with dementia, or is separately, it's just movement? Because I understand Parkinson is a movement disorder versus Lewy body, which is considered part of a dementia spectrum. So can you clarify a little bit about that?
Sure, Gloria. You know, that is a great question, and you are correct. So Parkinson's is mainly a movement disorder, okay? However, and what that means is that the predominant symptoms are the slowness, the stiffness, balance issues, trouble walking, and so on, right? However, about 30%, one out of 3 people with Parkinson's disease might develop something that we call the Parkinson's disease dementia, all right? And how this is this different from other types of dementia like Alzheimer's, right? So, you know, the typical dementia in Parkinson's is a dementia where your brain, just like your body is slower, your brain is slower as well. So the typical patient, you know, will tell me, you know what, doctor, sometimes I see somebody at the grocery store, I know who they are, I know their names, but I cannot remember their names. And then 10, 15 minutes later, suddenly the names comes to my mind, right? So somebody with Alzheimer's, the name will never come to their mind. They're not going to remember. And sometimes people with Alzheimer's, when they come, I tell them, this is the president and this is the year, and I give them 3 words, and they really cannot remember them. They cannot bring them back. Somebody with Parkinson's will tell me, you know what, these are 2 words, and the next one I just don't remember. And then 5 minutes later, they tell me, yeah, the last word was car or umbrella, right? So the dementia of Parkinson is a slow thinking type of dementia, a dementia that is typically mostly observed when people are trying to multitask. So, if you are cooking, watching the TV, listening to the radio, and balancing your checkbook at the same time, you are going to have an issue, right? So you have to do, one thing at a time. And that's what I tell people with Parkinson. You have to do one thing at a time, but it's not the type of dementia where you are going to forget who your grandkids are, who your children are. If that happens, what that means is that on top of the Parkinson's, that person likely developed Alzheimer's disease.
And that is common, doctor? People that develop like Alzheimer's or Parkinson's develop Alzheimer's or any other type of dementia?
Okay, so that's a great question as well. So the fact that you have Parkinson's does not mean that you are going to have Alzheimer's. The fact that you have Parkinson's does not increase the risk of you having Alzheimer's disease, okay? Now, remember that Alzheimer's disease is the most common dementia.
Dementia, yes.
So some people with with Parkinson's might develop Alzheimer's disease just because of the statistics. That is the most common dementia, and those are the patients that we call the PDAD. So they have Parkinson's disease, but they also have Alzheimer's disease, and we recognize those quick because the degree of the memory issue is different from people with Parkinson's.
Thank you so much, doctor. I think it's so valuable. I definitely, I can be like 3 hours with you, no problem, because this is a really good knowledge. That's why you're a top of the doctors in Orlando. We really appreciate your time. And it is anything else that you will recommend for anybody about like testing? If they feeling like they having some slowness, slow movements, there is not necessarily the tremor. I love what you clarified there, like, you relate Parkinson exclusive with the tremor. And so be in that situation, what to do? I mean, let's see someone approach and say, okay, I don't feel, what is those symptoms that you will say, it's good for you to visit a neurologist?
Yeah, so if the walking is getting slower, if you might be shuffling your feet a little bit, you find that everything is taking longer, much longer, and many times couples, we're both aging at the same time. But if you're noticing that, yeah, you're aging, your wife is aging, but you're even much slower than your wife, and you're having trouble walking, you have this stoop posture and so on. Every now and then you have some tremors, or you have the vivid dreams, right? If you have that, I think that at that time you should go ahead and see the neurologist. Okay.
What tests that people do what tests you do in a patient to know that has?
You know what?
Like,
so at this time we do an MRI just to make sure that nothing else is happening. And then we go ahead and do a formal and a very comprehensive physical and neurological evaluation, right? And that's where we find those symptoms. Parkinson's disease and these conditions are clinical diagnosis, right? There is a brain scan that is called a DAT scan, but that is not diagnostic of Parkinson's, okay? Be aware of that. Many people come here, yeah, I have Parkinson's because I have a positive DAT scan. No, that is not correct. What that is telling us is that there is a disorder in the brain of dopamine function, but it's not telling me that you have Parkinson's disease. There will be quite a few conditions that will have a positive DAT scan. Okay, but I think that the best advice that I can give people, just to summarize and wrap it up, is exercise, okay? You know, that should never stop. Stay busy with your mind, challenge yourself in terms of the cognition, you know, read useful things, go to the library, find a new book, find a new hobby, a new game that keeps your mind busy. Make sure that you're eating a healthy diet, try to sleep well. You know, those things are going to be critical.
And where
I'll
people
talk to you,
can
doctor.
contact you?
Well, you know what? I am in Orlando, Florida, Central Florida, and my clinic is Neurology One. That is the name of our clinic. I share office with it's myself and Dr. Benes. She's another Parkinson's disease and Alzheimer's disease specialist here in this area. Our telephone number is 407-916-0304, 407-916-0304, or you can just Google Neurology One, Orlando, Florida, and you will find our clinic. And, you know, we have a website with very useful information, and every so often we're posting videos and information on new things, especially when new research is published, right? We go ahead and try to explain that in simple terms for people to understand what to expect from those new medicines that have been approved.
Excellent.
Thank you so much.
Well, thank you. I really appreciate your invitation. I think that I always enjoy speaking with patients, and I think that you know, what the foundation is doing is something that is extremely necessary. Not much necessary, is extremely necessary, because navigating Social Security, navigating all these things that you know, all these benefits and all these programs that come, there's just too much noise in the background. You go to the internet and there's a lot of misinformation. So I think that what you guys are doing is what people really need. So I'm very thankful that you guys are doing that.
Well, thank you. You know, our mission, as I said earlier, is support and educate American seniors, and that's really, you know, what we've dedicated the foundation to do. And one of the main ways we do it is seminar offerings like this, and working with Vitas Healthcare. We have been blessed with a relationship that I think has produced a lot of meaningful information for the public. Working with Gloria and Chris, I know Chris was on earlier, but working with Gloria is just such a pleasure.
Oh, yes,
Aw,
I agree
thank
with that.
you.
I agree with that.
And you know, I love you, Dr. Rodriguez, in a good way.
Thank
I
you so
wish I
much.
can
Thank
have
you
you
so
here
much.
in Lake and Sumter. I
Yeah.
wish I can have you here, but every time that we can do this online, I will definitely knock on your door again.
Perfect. Sounds good. Anytime. Okay.
And
Thank
she
you
brings
so
us,
much.
Gloria brings us into contact with professionals like you, Dr. Rodriguez, that we really appreciate.
Oh, yeah.
Oh, my pleasure. My pleasure. Well, you guys take care. I appreciate the invitation, and blessings to all of you. Okay.
Thank you very
Thank you
much.
so much.
All right. Bye-bye.
Bye-bye.
Bye.